Hello, everyone, and welcome to our first asynchronous class. The topic of today is psychodynamic and relational perspectives, trauma, dissociation, and the self. So we first talked about trauma and dissociation last week. We spent a lot of time talking about it from a neurobiological perspective. Today, we're going to get some psychodynamic and relational perspectives on this topic. So we're looking at trauma not as a single event, but as something that reorganizes the self and shows up in the therapy relationship. This lecture connects Judith Herman's foundational trauma framework to psychodynamic and relational concepts that you already know, concepts like dissociation, transference, countertransference, and enactment. All right, so here are the learning objectives for this week. By the end of the module, you should be able to explain how trauma shapes the developing self, understand dissociation as an adaptive defense, identify trauma in transference and countertransference, recognize enactments in clinical work, so as they're showing up in real time in session, and apply Herman's phase model relationally. So again, this is about recognizing trauma in the room, not just taking a trauma history and getting our clients to regurgitate their traumatic experiences. All right, so a part of this asynchronous lecture was to read the first 3 chapters in Judith Herman's book, Trauma and Recovery, which should be available on the library website. So be sure to read those because it just gives you some really good groundbreaking information about how we conceptualize trauma, even though it's one of the earlier versions of trauma. This was written in 1992, but Judith Herman has since expanded upon this topic a few times. So the core idea is that trauma is a relational betrayal that reorganizes the self. So Herman is very clear that trauma is not simply what happened to you. This is also something that you hear me say a lot. Trauma is never about the specific experience. That's why 2 people can have the same experience, but it can live totally different in their body. This is because trauma is what happens in relationship, especially when the person who is being traumatized depends on the person who's actually inflicting the trauma, inflicting the harm onto them. So this is why trauma lives in relational patterns, not just memories. And because trauma lives in relational patterns, we can expect to see those patterns unfold in the therapy room. And this is when we're getting really relational in how we're conceptualizing trauma. All right, so on this slide, we're moving from event to organization of the self. So like I've been saying, trauma is not just what happens to a person, it's something that rearranges how that person must be in order to show up in relationship. So when Judith Herman talks about trauma, this is specifically what she's talking about. The parts of ourselves that end up being compromised in order to preserve survival, but also in order to preserve relationship, especially to attachment figures, to caregivers. So there's a few concepts that I want to go over on this slide. The first one is fragmented self states. So this part can get very confusing and a little convoluted. So for some background information, just make sure you brush up on Melanie Klein's idea of object relations and the paranoid schizoid self, which is talking about how the psyche splits and going into that psychodynamic perspective. You also might be interested in looking into internal family systems model or parts therapy. They talk about basically the same concept about how the psyche fragments, our self states end up fragmenting in order to preserve survival and relationship. So at its core, this fragmented self state is saying that a child cannot hold that the person they need is hurting them. So instead of losing the attachment relationship, the mind splits into parts. One part knows what's happening behind the scenes. One part feels, but one part survives. One part is staying loyal to the caregiver. But the thing about these parts that become fragmented and split is that they don't communicate well with each other, because communication would threaten survival. Again, at the very extreme level of this is things like dissociative identity disorder. But parts therapy and relational models would say that this is not like, this happens to humans, not just in the extreme of DID, but that we all experience this, likely to a lesser degree. So think about it on a spectrum, like I told you to think about dissociation happening on a spectrum. This is also important to think about because for many clients, this dissociation started very early on in life when they were inadvertently and many times implicitly taught to suppress parts of themselves in order to survive. So the next concept is discontinuity in narrative. This is why trauma survivors often tell stories that feel really fragmented or disjointed, maybe very intellectualized, overfactual, and emotionally flat. And we talked about this last week when we went over the fragmentation in the hippocampus and how that relates to trauma survivors sort of remembering in very fragmented and disjointed kind of ways. So this is looking at it at the level of relationship and at the level of psyche. And basically saying that the narrative is not linear because the self, that part of that person that lived the experience, is not fully integrated into the self that's telling the story. So that traumatized child not being fully integrated into that adult who hasn't really been able to look back at that traumatic experience in an embodied and integrated way. So you're basically hearing the voice of one self state trying to describe something another self state had to contain. And this is basically saying that's why you feel that disjointed or emotional flatness in a lot of trauma survivors when they're recounting their stories. So the next concept is loss of coherent identity. So basically saying over time, if a person has to repeatedly suppress authentic emotional responses, suppress who they are authentically in order to maintain attachment and relationship, this theory is saying that they lose access to a consistent sense of who they are. So they become, people pleasers or who others need them to be, the safest person that they can be in order to survive that relationship. The person who compromises their values in order to maintain a sense of belonging. So this is where you see identity confusion, compliance, over-compliance a lot of the times, but also I would say sometimes combativeness and a chronic sense of not feeling real in our trauma survivors. So the next concept is reliance on dissociation to preserve attachment. So very similar to what we've been talking about moving before in this lecture. And this is really the most important part. So dissociation, like I've been saying, it's not primarily about avoiding pain. I know a lot of the times when we talk about dissociation, we talk about someone getting out of their body in order to avoid something painful or uncomfortable happening to their bodies. But it's not just about avoiding pain. It's about preserving relationship. So a child will give up anger, fear, protest, and authenticity before they're going to give up the connection to a caregiver, because that child has a biological urge. Everything in that child is screaming to seek proximity to their caregiver, even when their caregiver is threatening or unsafe. So they're going to compromise parts of themselves in order to preserve that relationship. Now, if you're interested in this, Dr. Gabor Mate talks a lot about this idea in his book, The Myth of Normal. He doesn't frame it as a dissociative response. I see it as a dissociative response, and maybe you can read the book and tell me what you think about it if you also see what he's talking about as a dissociative response. But in The Myth of Normal, he basically talks about how we trade authenticity for attachment. So a child learns, if I don't feel this, I don't lose them. If I don't feel anger, I don't lose my parent. I once had a client who's was just naturally very gentle and very loving, but they had a caregiver who projected their own insecurities onto their child's behaviors and saw their child's behaviors as being overly feminine. So that child learned to suppress parts of himself in order to preserve his relationship with his father. So this is basically the foundation of dissociating from a part of ourselves, many of the times on an implicit level, in order to preserve relationship. So again, we talk so much about how things that work, these reflexive, defensive strategies that work beautifully in childhood, end up causing self-sabotage, self-erasure, and just maladaptive patterns in adulthood. Because in adulthood, this can look like a child who has very flat affect because they cannot connect to their emotional body, or someone who has overcompliance or maybe undercompliance. It can look like someone who's very good at talking about their emotions, intellectualizing situations without really being able to connect to themselves. So the final part of this is just gaps in narrative, someone feeling really far away from their own experience. So if you think about the definition of dissociation and depersonalization and derealization. And this slide is just to further drive home that point, because I know when I talk to a lot of students early on in their training, or even just the way that we're trained in this field in general, a lot of us are trained to pathologize symptoms as opposed to looking at those symptoms through their adaptive lens. So dissociation is more than just pathology. It's nervous system intelligence, someone who cannot dissociate away from pain or from these situations, they're going to have a really hard time in relationship. So the fact that someone can dissociate actually shows that their nervous system has a bit of intelligence to it. Dissociation is protective. It's protecting that self. Even if you look at that image, you see like the inner child inside of like those fragmented parts of the self. Like there's a part that's being protected through the dissociation, and it's relationally loyal. And this is how people in adulthood could run into problems, like maybe they just dissociated and learned to please the people around them in order to survive childhood. But now they don't like the way they show up in adulthood because they're constantly putting their needs aside in order to please others. And dissociation at its core is a survival strategy. So Judith Herman also talks about looking at like the brilliance of dissociation as an adaptive response. All right, so why dissociation appears in therapy? Well, one, we all have nervous systems and we all have life that's lifing in the background. So if we're thinking about dissociation as a spectrum, we all dissociate to a certain extent. Some of us, or most of us, just don't dissociate to the point where it now has clinical significance or any kind of clinical pathological level. So dissociation appears in therapy like flat affect, compliance, intellectualization. I know what happened, but I don't feel it. Gaps in the narrative. It's showing up in the therapy room because it's cluing us in on what's happening inside the person's mind. And it's also giving us some really useful information about how our clients experience their life and some of the residue. I sometimes think about trauma in terms of the residue that gets left behind. Some of us move on, but maybe there's still the residue. There's still instances of the trauma that are stuck in parts that we're not communicating with, and it stays stuck, and it comes out sometimes as self-sabotage or repeating patterns, cyclical maladaptive patterns. So dissociation is just very good. It's very clinically useful information that can give us a lot of information that our clients may not have conscious access to themselves. All right, so this slide is talking about Judith Herman's phase model. And this model is foundational for understanding trauma treatment from a relational and psychodynamic perspective. So Herman is very clear that trauma recovery is not about insight first. It's about sequence. And many clinicians get this wrong. Even if they think they're doing trauma treatment, they go straight for trying to invoke insight and remembrance and reliving the trauma, and wonder why therapy stalls or becomes overwhelming or just results in more dissociation. So, like you read in chapters 1 through 3 of Trauma and Recovery, Herman is telling us that healing must move in 3 phases and that the order is not optional. Now, the first phase of good trauma and recovery treatment is safety, like we talked about in our first few classes. Before a person can tell their story, their nervous system must believe that they're no longer in danger. Safety is not cognitive, it's physiological, it's relational. So, this is where the regulation actually happens. Things like predictability of schedule, containment, setting healthy boundaries, how steady the therapist is. This is going to promote safety even in our clients who have never physiologically felt safety. You being a stable, regulating presence can help teach them that new experience. And most early trauma work is actually happening at this stage. But the thing that trips a lot of early clinicians up is that this stage can feel really uneventful because it doesn't look dramatic. It looks slow and even repetitive as clients move towards safety, and then maybe things happen in their life where they kind of draw back from safety. So it looks uneventful, but this is where dissociation begins to soften because the system no longer has to protect itself so intensely and so reflexively. So if we skip this phase and push straight for trauma processing, you're just going to increase dissociation. Phase 2 is remembrance and mourning. So after safety is established, this is when the person can begin to remember. This is when you start actually working on processing the traumatic memory. So after remembering, it's not just telling the story, it's feeling what has never felt safe to feel. This is why we need our clients to be embodied. We need their nervous systems to be moving towards regulation before we're dredging up very dysregulating traumatic memories. So this phase includes grief, anger, loss, mourning the self that had to fragment in order to survive, mourning the parts of themselves that they may feel like are lost because of their experiences. This is where narrative becomes continuous rather than fragmented. So when you have a client, again, who's very fragmented, you go back to safety. And then once they start to be able to tell the story in more integrated way, that's how you know they're ready for trauma processing. Because sometimes clients push back. Sometimes they feel like a lot of our traumatized clients can feel like things like reassurance can feel like the opposite of what we want them to feel. They can feel unsafe or they can feel dangerous. So I've had clients who may want to push for trauma processing because in their mind, all I have to do is talk about it and then I'm done processing the trauma. So if you have a client and you're experiencing that, you can just continue to move towards safety, even if it's just meeting them halfway, and before they independently bring up any kind of traumatic memories, make sure you're doing some kind of regulatory practice in the beginning. But you want to keep them to this phase as much as you can. And your role in this second phase is to pace the work so that remembering does not exceed the client's capacity to stay present. So think about those techniques that we learned last week. The titration, the pendulation. You want them to be able to touch the traumatic memory without going out of their body, without dissociating, so that you can actually accomplish meaningful trauma work. Now, phase 3 is reconnection. I like to call this stage integration. This is where the person begins to live differently, not just understand themselves differently, not just gain insight, but live a different life. They connect to relationships, their body, more connected to their body, more connected to their identity and sense of self, more connected to a future. They're more future oriented in this stage. And clients may independently start talking about these things, and that's how you know that they're moving towards reconnection. They're moving towards integration. What's interesting is this phase is often missed in therapy because clinicians stop once insight is achieved. I had some colleagues, and once a client discloses a lot of insight, they're ready to, kind of wrap things up. Like, okay, we finished the trauma processing. If we think about trauma focused CBT, it's a really great intervention. But a part of that intervention is once you finish the trauma processing, you start wrapping it up. But really, you want to help the client through this reconnection stage. Because reconnection is behavioral, it's relational, it's embodied. It's going to show up in how someone chooses their relationships, how much they're able to tolerate closeness, affection, and intimacy now, and also just the experiences that they have in the world and of themselves. So if you're feeling stuck with a client, you can ask yourself, which phase are we actually in? Not where you wish to be, not where the client wants to be, but where their nervous system is. Most trauma therapy problems come from trying to do phase 2 when the client is still in phase 1. And dissociation is often the sign that this sequencing has been disrupted. So I guess to wrap up this slide, I would say trauma recovery is less about what we talk about and more about whether the nervous system feels safe enough to talk at all. All right, so this slide captures one of the most important ideas in psychodynamic and relational work, which is that trauma does not stay in the past. It re-enters the room through relationships. So clients don't simply talk about trauma, they're going to relive them in the relational patterns with you, and that's going to give you some clues on how they're reliving these relational patterns with other people in their world. So this is something that they're doing with us. And like I said before, trauma therapy is not just about gaining insight. It's about recognizing when the past is being replayed. And you can do this right in the therapy room by seeing how it's replayed with you. The work does not stop happening. So this talks about transference, countertransference, and enactment, which we're going to go into more detail in the subsequent slides. But the work is just to notice it, slow it down, and respond differently than the original relationship did. This is called giving our clients a corrective experience. So if you have a client, like I once had a client who had a very abusive relationship with their mother. And even though I was about 20 to 30 years younger than this client, it's like I automatically became their mother, and they started to try to do things to sometimes appease me, or sometimes they projected anger and blame onto me. So again, my job was to notice what was happening, to slow things down, and to offer them a corrective experience. Like with this client, I had to offer them the fact that I could continue to remain secure and caring despite them doing things that may have disappointed their mother or may have angered their mother. So giving them a new relational experience, because that's how integration begins. So let's go into detail about transference, countertransference, and enactment. All right, so you can think of transference as templates from earlier relationships that are being replayed in the therapeutic relationship. So this is where the client begins to experience you not as who you actually are, but as someone from their past. And that example I just gave of my client viewing me as their mother. So you may be experienced as critical or abandoning, or maybe you're idolized or unreachable. Maybe they experience you as responsible for their safety. We kind of saw this playing out in treatment episode that we watched in class, where she was now pulling on her therapist to be responsible for her safety and responsible for the raising of fathering her child. So these reactions are not random. They're organized by early attachment experiences, and this is why we want to notice them and pay attention. Again, we're not pathologizing them. We're not looking at them to view what's wrong with our client. We're looking at them to say, hey, our client had some kind of early attachment relationships that created a template, and this template is now being reenacted in session. So our clients are not being dramatic. Their nervous system is trying to make sense of their world using old relational maps. So think about maladaptive traits, traits that were once adaptive now showing up maladaptively in relationship. All right, so next we have countertransference. And these feelings often belong to the patient's dissociated self states, the parts of themselves that they may not be able to access, but we're still feeling in the room, right? So this is where the therapist begins to feel something that seems to come out of nowhere. It seems unrelated to their authentic sense of self or how they're showing up in the room. So you may feel sleepy during session or after session with a client. You may feel confused, overly compliant, like you're trying to please the client, like you don't want to disappoint them. You may feel a sense of urgency to take care of their needs or an inflated sense of responsibility to fix their situation. You may even leave the session feeling ineffective despite, feeling fine during the actual session. So these reactions are not personal failings, they're clinical data. That's what countertransference is talking about. And it often tells us what the client cannot yet consciously communicate. So that's basically how we use our regulated embodied presence to kind of feel what's in the room, even when it's unspoken. So to feel those unspoken dynamics. All right, so the last one is enactment. When I talk about enactments, and especially when I'm working with a lot of students, especially students at Widener, I saw a lot of them trying to avoid enactments, like they're viewing it as a mistake or a very bad thing. But enactments are not as mistakes, and I would go as far as saying that according to relational and modern day psychodynamic therapy, we view enactments as inevitable, but because it's useful clinical and diagnostic information. So this is basically where both the therapist and the client are now inside the old relational pattern without realizing it. So instead of just the client projecting onto the client, instead of just the client projecting onto the therapist, or the therapist feeling something and projecting it onto the client, they're both sort of hooked into this dynamic together, reliving old relational patterns. So in order for an enactment to happen, you can think of two people as needing a hook. And if two things fit, right? Like if you went into this profession because you were a caretaker, you were parentified, you took on the emotional responsibility of an adult, and you have a client who has narcissistic traits, those usually go hand in hand. An enactment is almost inevitable to happen in that dynamic if you are not fully aware of your values and reasoning for showing up in therapy, right? Because this is all happening at an unconscious level. So for enactment, you may find yourself rescuing, over explaining, withdrawing, becoming overly directive. Like I've seen this happen where some students feel like they need to set really firm boundaries with clients from the start, even though their client may not give them an indication. Like I had one student who read in a client's chart that they had like borderline personality traits, and they themselves grew up in an environment where someone had these borderline traits. So before the client even showed up, they were thinking about all the boundaries that they needed to put in place. So by the time they were in the room with the client, enactment was already happening. So you're responding to the client in old relational patterns, and the client is responding to you in a way that completes that old pattern. So again, it's not a mistake. This is the moment where trauma is the most alive in the room, and therefore the moment where the most healing is possible if it's noticed. And this is where they talk about that third space in psychoanalytic therapy. If both of you can kind of, or at least you who's holding the situation as a therapist, if you can kind of notice your feelings and step aside from the situation, you can kind of create that objective third space, or as objective as it can be, where you can now have a different reflection on what's happening in the room. And that's where that corrective experience is born. So for that example I just gave with that student that I was working with who sort of got into this enactment with a client, they had to notice during supervision that they were getting pulled into this dynamic, just having them reflect on. I had them reflect on, why they needed to put up such harsh boundaries before they even started with this client. And that's when things started to open up about their nervous system automatically protecting themselves, because they were experiencing traits from their client that they had experienced in their childhood. So both of them were basically swept into a nervous system stress response, but you can become aware of that. And that is how you take enactment and turn it into a very powerful healing experience. All right, so for this next section, we're going to pause and you'll do a little bit of work on your own. So you'll see two things on this slide. This is the relational trauma and therapy viewing assignment. There is a YouTube clip here, and I'll be sure to put this on Canvas as well. This YouTube clip is like 34 minutes. You do not have to watch the entire clip unless you like The Sopranos. It's basically from the show The Sopranos. It's their therapy sessions. It's Tony Soprano's therapy sessions. I want you to choose one of those therapy sessions and then just follow the instructions that you see on Canvas, where you're going to think about the dynamics that are playing out, think about dissociation and just the different phases of dissociation. Because again, we talked about how people, when they think of dissociation, they rush and think to DID, but sometimes a dissociative response is a client sort of becoming angry because they're getting pushed out of their present self state and into a defensive self state. So just think about the different layers of dissociation. You can scan that QR code and access the file, but I'm also realizing that I left it published. So many of you have already saw the assignment. So this is just a section of the lecture where you go ahead onto Canvas and complete that assignment. All right, so here are some reflection questions. So after watching the Sopranos clip, I want you to write some brief self-reflections responding to the following questions. Again, this is not a written assignment that you need to turn in, but I do want you to engage in this assignment, engage with this material. So identify at least 2 moments of dissociation. What did you observe that signaled emotional absence despite verbal engagement? This can be in the Sopranos clip if you want something that's less personal, but you can also talk about that in your own experiences with treating clients in therapy. Identify at least one example of transference. So this one's going to be for the Sopranos clip. Which relational pattern was Tony replaying with Dr. Melfi? Describe a moment of countertransference. Where did you observe a relational enactment beginning to form? And how does this session illustrate the idea that trauma reorganizes the self and reappears in relationship? So again, you can journal these, you can just write it on your computer. These are just some self-reflection questions to help deepen your understanding of this material. All right, so now we're going deeper into trauma and recovery. I wanted to talk about some things that you should not do in session. So this slide names the 3 most common clinical errors that happen when therapists work with trauma-organized clients, especially those who dissociate. So this is very common if you're doing trauma work. Again, the presence of this does not mean that you're failing or that you're doing it wrong. It's just things that you can keep in mind so it can help guide you as you're guiding the client. So these errors usually come from skill, confidence, and good training. Like I said before, they're not signs of incompetence. They're signs that the therapist is applying standard therapeutic logic to a nervous system that isn't ready for it, because that nervous system is still operating by survival logic. That survival brain is activated. So trauma treatment is not about doing more. It's actually about doing less, more slowly, and more relationally. That's what trauma work is. So the first do not push for emotional processing. So when a client is dissociating, they're not emotionally absent because they're resistant. And I feel like this was talked about a lot in the early psychodynamic works on resistance. I think we had a lot of dissociative clients who were being labeled as resistant or defiant, but I think that's just because the neuroscience did not catch up, or psychodynamic did not catch up with the neuroscience that was available at the time, right? If the client is emotionally absent because their nervous system has determined that the feeling is unsafe, it's going to look like resistance. And if we push for emotional processing here, what we're actually doing is asking the client to leave the very survival strategy that kept them safe. So it feels like harm. And this is what I meant when I said some clients who've never felt safety are often mislabeled and pathologized because they're being pushed to do things that are outside of their nervous system's capacity at the moment. It doesn't mean that it's always going to be outside of their capacity. It just means that you need to add in more buffering before you move forward. So going back to phase one helps with this. So if this pops up again, it's very common. You may hear yourself saying things like, what are you feeling right now? Can you sit with that emotion? Let's go deeper into that feeling. Like, all of these questions sound really great, right? But if the client's nervous system is not ready, this is not creating integration. It's increasing dissociation. So again, it may look like they're gaining great insight. They may be able to regurgitate back to you what the interpretations that you're trying to make, but odds are they're still dissociated. So again, the client may become compliant. They may even seem more articulate, more insightful, but they're less present. And that's something, if you're embodied in the room, you can feel when your client's presence is slipping away. So the second do not is do not interpret too early. This can be a very hard thing for early clinicians. I feel like we're so skills-based when we're teaching you how to be clinical psychologists. We want you, or I this is at least what I resonated. I wanted to make the best interpretations. I wanted to help my clients heal. I wanted to help them reconnect with their lives. But then once I learned more about trauma processing and treatment, I saw that interpretation too early was actually not the best tool. Interpretation is a powerful tool, but interpretation assumes the client has enough integration to metabolize what you're offering. Have you ever heard anyone give you information that you're not ready to metabolize? It feels very unsettling. So that happens a lot of the times when we're rushing to interpret a dynamic that our client may be stuck in, but they're not ready to see yet. So when a client is associating, interpretation lands cognitively, but not relationally. So I know I gave some examples of this already, but some other examples are, you may say something really accurate to the client, like, I wonder if this connects to how your father treated you, or it seems like you're reaching an old relational pattern. And the client could nod and even say something like, yes, that makes sense. But nothing changes. And the next week, they may do the very thing that you all just talked about not doing. Or the next month, this pattern may come up again. Because interpretation requires a self that is completely online, or at least online enough to receive that information. So not completely online enough to receive that information. So dissociation means the self is fragmented across states. At the extreme end of that, it looks like DID. But for most of our traumatized clients, it's still looking like fragmentation. If you can pick up on it, if you can start to notice the signs. So the insight has nowhere to land, basically. The last one of like what not to do is do not assume insight and equals integration, which I've been saying this entire lecture. This is actually one of the biggest traps. And I fell into this trap many, many times as an early clinician because I was trained that our goal was I was trained in a program that was very cognitive behavioral therapy. It was a CBT program. So we were trained that the goal was to promote insight. So that's just an issue with how we train clinical psychologists, right? But from a trauma-informed lens, trauma clients are often very insightful because they work with many people who have shown them their patterns, right? They can describe their history beautifully. They understand their patterns. They can explain their trauma with clarity. And yet they're still living inside the same relational patterns. Why? It's not because they're doing anything wrong or because they don't want to get better or because they're resistant. It's because insight is a cortical function. Integration, however, is a nervous system and relational functioning. So that's important to keep in mind. And we talked about that a lot in the lecture on the neurobiology of dissociation. So I won't go into any more detail with that. So a client can understand everything and still be dissociated from it. So the last thing I want to say on this slide is that these three mistakes all come from the same assumption. If the client understands, they are integrating. But trauma work teaches us, true trauma work teaches us the exact opposite. If a client is safe and present, integration becomes possible. Insight can come later, and actually now in our the way the field is moving into trauma processing, especially if you look at the work of Dr. Peter Levine, is that we may not even need to revisit those old memories in the way that we used to in trauma treatment. Really, the goal is presence, safety, and integration. Insight is great, but insight can come after that. So this slide is not about technique. It's about shifting your orientation from doing therapy to the client to being therapy with the client. And even if you look at the work of Carl Rogers, in unconditional positive regard, or a lot of the research on what is the common factor that promotes healing in therapy, they say the therapeutic relationship. Now, if you put this lens, the psychodynamic relational lens, in a neuroscience lens, it's saying the therapeutic relationship is so healing because that presence is what's regulating the client or helping to regulate the client. All right, so now let's talk about what to do. So this slide is basically the clinical posture that you want to take when you're doing trauma treatment. Up to this point, we talked about how trauma shows up in the room through transference, dissociation, enactment, and your own internal reactions. But now we're moving into how you respond when you recognize it. So you can think about these as techniques, but I think it's more useful to think about them as regulation principles that change the entire tone of the session. So the first is to slow down. When trauma is activated, the nervous system speeds everything up. Speech speeds up, thinking speeds up. The therapist feels pressure to do something about what's happening. So slowing down is not passive, it's an intervention in itself. And you're countering the client's survival tempo with regulation tempo. So it's a very, very useful technique. This can look like taking longer pauses, asking fewer questions, just letting silence exist and letting your regulated presence do the work. It can look like speaking more slowly than feels natural. You're basically lending your nervous system to the room. So if someone's really activated and amped up, your presence just naturally slowing down will likely cause the client to match that tempo and help them to slow down. So you're co-regulating your client through slowing down. The second is increased presence, which is very similar. So presence is different than talking, interpreting, or analyzing, which is the way that a lot of clinicians are trained, that in order for us to be useful, we have to be doing therapy to our clients. So this is a little counterintuitive to how we're actually trained. I don't think it's counterintuitive in practice, but it's just different than how clinicians are usually trained, right? So presence means you're tracking the person, not the content. You're aware of their face, their breath, their posture, their tone. You're aware of yourself too. You're aware of yourself in your chair because trauma fragments attention. Your presence is what's going to help restore integration without forcing it. So often the most therapeutic thing happening is that someone is fully present while the client is not. The second one, or the third one, is track affect and body. So if the story is fragmented, do not chase the story. Do not ask them to fill in the gaps or why there may be gaps in the story. Instead, follow with facial shifts or changes in voice, breathing patterns, muscle tension, eye contact, posture changes. The body will tell you when dissociation starts before the client is aware of it. So in this instance, you may say something like, I noticed your voice got quieter just now, or I see your shoulders pulled in as you said that. Again, this is not being hypervigilant to overanalyzing or knowing everything. And again, it can feel tricky to get this. So it's something that I'm still developing. It's something that you're going to take a while to develop, how to be present without doing anything, without interpreting or analyzing. So this is what helps keeps traumatized clients anchored in present moment experience rather than disappearing into a memory or narrative, because that's often easier to do. Talking about something, talking through issues is often easier than being present with that discomfort. So the last thing is just always prioritize safety. Safety is not comfort. It's not being overly reassuring. Safety is nervous system regulation. Before insight, before processing, before trauma narrative, ask yourself, is this person regulated enough to go here, even if they're trying to go there themselves? If not, return to phase one, return to grounding, return to orientation to the room, even if it's just you stopping and saying, I think it'll really benefit us to do a breathing technique right now. Just in the beginning of trauma treatment, I like to get client buy-in on what coping regulation skills they like the most. And I preface the beginning by saying, hey, there's sometimes in therapy where you may not understand why I'm stopping or slowing us down, but my goal is always going to be to prioritize your safety. So this is when you may go into that mode. Orientation to the room, relational connection, here and now awareness, because trauma work done without safety is just re-traumatization. And unfortunately, there's a lot of, I don't want to sound too critical, but there's some poorly trained trauma-informed approaches that lead to re-traumatization because it's skipping past safety and just trying to promote insight. It's skipping phase one and moving straight to phase two. So here's the big teaching point. For beginning clinicians, we often think that good therapy is about asking good questions, making great interpretations, or doing that deep processing. But in trauma work and neurobiologically informed trauma work, good therapy is about tempo, cadence, presence, tracking, safety, and rhythm. So speaking directly to the nervous system. You are not moving the client forward. You're creating the conditions where the client's system can safely come back online. All right, so we're nearing the end here. Up until now, you've been learning what trauma does, but here you begin to understand what therapy is actually doing. So therapy is not primarily insight. Therapy is not primarily technique. It's not primarily interpretation. Therapy is a new relational experience that the client's nervous system has never had before, that corrective experience that I've been talking about. So with the therapist as a relational field, you become the new attachment experience. For many of our traumatized clients, especially those with developmental trauma, attachment has always been unpredictable, emotionally absent, dangerous. Maybe it's come with role reversal or abandonment. By role reversal, I mean things like parentification, being the emotional scapegoat of a family system as a child. So when a client enters therapy, they do not experience you as a therapist. They experience you through the only template they have for relationships. So think internal working model. So they'll expect you to leave. Traumatized clients are going to expect that you're going to misunderstand them. They'll expect you to cause harm to them. They're going to expect that you're going to fail them. And how you respond to those expectations is the treatment, right? Not what you say, not what you interpret, but how you remain with them when their instinct is telling them to dissociate away from the situation. So this is the place where dissociation softens, because again, dissociation is not removed by insight. It softens when the nervous system no longer needs it. So that happens when the client feels emotionally safe, when they feel relationally held, when they feel not rushed to look at hard experiences, when they feel like they're not required to perform, when they feel like they're not required to explain themselves. So over time, the client begins to stay present longer, not because you ask them to, but because they no longer need to leave their body in order to feel safe. So this is why things like slowing down matters. This is why presence matters. This is why safety precedes story. All right, so the place integration becomes possible. Integration is what happens when a client can be present in relationship while they're experiencing emotion, memory, and their self simultaneously. And that has likely never happened before with our traumatized clients. And it does not happen because you guided them there. It happens because the relational field that you created in the room made it possible. So if you think about it, this reframes our job as clinicians. We're not leading the client toward healing, we're becoming the environment where healing can occur. All right, so as we're finishing up this lecture, I want to talk about clinical anchors. So this slide gives you something that you desperately need when doing neurobiologically trauma-informed work. Neurobiologically informed trauma work. So what you need is a way to orient yourselves when you feel lost, because feeling lost it just naturally comes with the territory when you're doing trauma work. Because in trauma treatment, confusion is not a sign that you're doing something wrong. Confusion is data. And this slide teaches you how to read your internal state as part of assessment. So if you're feeling confused, look for dissociation. When a therapist suddenly feels foggy or confused, mentally scrambled, or like they're having a hard time following the client in session, it's easy to assume that the client is not making sense, or that you're missing something, or that you need to ask better questions, be more productive. But usually what's happening is that the client is dissociated, and the therapist's brain is beginning to mirror that state of dissociation. So that is what can feel like confusion internally. And dissociation spreads across the relational field in a room. So instead of pushing for clarity, which can often be the instinct, the task becomes slow down, ground, help the client come back into the room and back into their body, because clarity returns after presence returns. So you first, if you're feeling confused, you're feeling your client is dissociated, you want to ground, slow down, go back to phase 1, because that's when clarity can be reborn. So the second part, if the story is fragmented, we have this instinct to protect safety. Or if the story is fragmented, your instinct should be protect safety. So a fragmented narrative is not an invitation for you to organize the story for the client. You don't have to say, hey, last week I thought you said that your brother fell off their skateboard when they were 5, and now you're saying your brother never had an injury. That's not the time for that, right? A fragmented narrative is not an invitation to organize it. It is evidence that the nervous system does not feel safe enough for coherent memory. So again, students often want to help the client tell a better story, but the correct intervention is don't push the story, protect the safety, because story is going to organize itself once safety is present. And the last clinical anchor to really help you when you're doing good trauma work is if you feel urgency, check for enactment, because odds are there could be some kind of enactment that there's something that you're getting pulled into, right? So urgency in session with traumatized clients is one of the clearest signs that you've been pulled into an enactment. So you may feel an urgent need to fix, to rescue, to do something productive emotionally. You may feel an urge to make something happen. But again, that urgency that you're feeling doesn't belong to you. It belongs to the client's relational history, which is replaying itself in the room. Or there could be some pieces in enactment that actually belong to you, right? So the move is not to act. The move is to pause and ask, what role am I being pulled into right now? And that can be hard to do, but again, that's just something that's gonna come with practice. You don't have to, I don't want you all to hear this lecture and think that you need to master or conquer all of these concepts and techniques right away. A lot of this is going to come from experience as you gain more experience living embodied within yourself. That's really how we can help our clients live embodied. And embodiment is so important when we're doing trauma work, or else we often will get swept into enactments. So to summarize, The slide is reframing countertransference from a problem into a compass, right? So instead of something that we need to push away, it's something that's orienting us. Your internal reactions are not interference, they're clinical anchors. All right, so this is a slide where learning turns inward. Up until this point, you've been thinking about your clients, but now you have room to think about yourself in the therapy space. And for many trainees, this is the first time that you may realize that your internal state is part of the clinical picture. So, the first reflection prompt that I want you all to think about is think of a client where you felt unusually calm, confused, or responsible. These responses are usually not random, they're classic countertransference markers in trauma work. Feeling unusually calm is often a marker that the client is dissociated and that the therapist's nervous system has matched that shutdown response. Feeling confused is often narrative fragmentation. Like if someone's telling you a story and you're lost because there's no clear connection between what they're saying, that's narrative fragmentation and dissociation that's showing up in the room. And if you're feeling overly responsible, that's often signaling that there's enactment that's happening in the background, where the therapist is being pulled into this rescuer, parent, or stabilizer role from the client's past. And for the second prompt, I want you to think about how might trauma have been present in the room, right? So this question shifts the frame from what was wrong with me in that session to what was the trauma asking me to hold, right? So you're learning to see trauma as something that organizes the relational space, not just the client's symptoms. And this is really how we move beyond pathologizing our traumatized clients and working directly with the nervous system, as you've been hearing me say. All right, so here, as we wrap up, are the key takeaways. This slide is where you sort of gather everything that we've been talking about in this lecture. The first key takeaway is that trauma reorganizes the self. Trauma is not an event that happened in the past. It's an organizing principle of the person's present experience. It's something that happened and dysregulated their nervous system, and it's continuing to play on loop. And that loop is showing up in their relational experiences. It changes how emotions are felt, how memories are stored, how relationships are experienced, how the nervous system allocates safety and threat. So it can often feel like we're treating symptoms, but really what I'm hoping to show you all is that good trauma work is working with a reorganized personality structure without jumping to pathologize it or rushing to get rid of it or to treat it away. The second key takeaway is that dissociation is adaptive, right? Dissociation is not pathological, it's protective. It allows the clients to survive something stressful. It allowed our clients to survive something stressful. So when we stop trying to break through dissociation and start respecting it, therapy just becomes safer and more effective. The third key takeaway that I want you all to remember is that therapy reactivates relational patterns. So the therapy room is not neutral. The therapy room is never neutral. It's a living stage where our attachments, our clients' attachments, trauma, survival strategies are all replaying in real time. So it can look like things like transference, countertransference, and enactments. These are not side effects. These are where the work is actually happening. This is why we don't run away from relational ruptures. We just sit with them. The second key takeaway is safety precedes story. So students are often trained to get the narrative, right? Like, did they disclose their trauma? But trauma treatment requires the opposite order, right? First, we focus on nervous system safety. Then we focus on emotional presence. And only then can we focus on the story after those two points have been accomplished. So without safety, story leads to re-traumatization and further dissociation. This is why I'm so passionate about teaching proper trauma treatment, because we don't want to re-traumatize our most vulnerable clients. And then the last takeaway is that your reactions are clinical data. And this is often such a powerful idea to trainees because we're evaluated on how much we show up in session and what we feel. I'll share a personal example. I once had supervision, and I was working with a traumatized client, and I just disclosed to my therapist, I disclosed to my supervisor, Freudian slip, I wonder what that means. I disclosed to my supervisor just the reaction I was having to the client, feeling really pulled in, having trouble with boundaries. And then I saw that on my evaluation as something that I needed to work on. So I think that happens to so many of us when we're training to do this work, that it makes us feel like we need to push down our experiences and our feelings. But I'm teaching you the opposite. I'm teaching you that your confusion, your calmness, your urgency, your rescuerness, your protectiveness, your irritation, they're not personal failures. They're information about what's happening in the therapy room. So we don't want to push them down and avoid them. We want to be able to sit with them. So when we can learn how to read ourselves and our somatic experiences, that's when we learn how to read trauma, right? So if you remember nothing else from this lecture, remember these 5 lines. Trauma reorganizes the self. Dissociation is adaptive, not pathological. Therapy reactivates relational patterns. Safety precedes story, and your reactions are clinical data. All right, so you have officially made it to the end of this lecture. I hope you all enjoyed it. If you have questions, please let me know. And here's how I want you all to prepare for next class. We'll take about 10-15 minutes of next class and have just like a small group discussion of your reactions to this lecture. So be prepared to discuss a client, where you've noticed association with this client, and where you may have participated in an enactment. All right, I look forward to seeing you all next week, and I hope you have a great week. Bye.